This is a technical note for a revision ACL, PCL, and MCL reconstruction with primary FCL reconstruction after a first-stage bone grafting procedure. The disclosures for the senior author are listed. The patient is positioned in the supine position on the operating table and is induced under general anesthesia. A knee exam, including Ligament, pivot shift, posterior drawer, dial, and varus and valgus stress testing is performed to validate clinical exam findings. The posterolateral corner is approached first with a 10 cm lateral hockey stick incision centered over the mid-portion of the IT band. Dissection is carried down to the superficial IT band and bicep femoris tendon, and a common peroneal nerve neurolysis is performed. The biceps bursa is entered via small horizontal incision to locate the distal attachment of the FCL, and a tag stitch is placed. A fibular head guide is used to drill a guide pin through the FCL fibular head attachment about 8 mm posterior to the anterior margin of the fibular head. This is overreamed with a 6 mm reamer, and a passing stitch is placed. The IT band is split 3 to 4 mm proximal to the femoral FCL attachment using the tag stitch to tension the FCL and determine its femoral attachment location. A guide pin is drilled through the FCL femoral attachment. This is overreamed with a 6 mm reamer followed by a 7 mm tap, and a passing stitch is placed. A channel under the superficial IT band is created to later pass the FCL graft. The medial side is approached next with an anteromedial incision. Dissection is started over the vastus medialis oblique musculature and carried down to the hamstring tibial attachments. Both the semitendinosus and gracilis tendons are harvested using an open hamstring harvester. Both tendons are left attached to the tibia. Measuring 6 cm distal to the joint line, 2 Q-fix anchors are placed at the anatomic distal tibial attachment of the MCL. Both grafts are sutured to the tibia with the Q-fix anchors. On the femur, the adductor tubercle is found first to help identify the medial epicondyle. The MCL attachment directly posterior and proximal to the medial epicondyle as identified. A guide is placed at the center of the MCL femoral attachment, and a guide pin is drilled anterolaterally across the thigh. The guide pin is overreamed with a 7 mm reamer to a depth of 35 to 40 mm. The hamstring autografts are passed through a soft tissue channel created under the sartorial fascia and cut and whip stitched so 30 mm of the graft will fit into the tunnel. Using the same incision, a central third BTB autograft is harvested with a 10 by 20 mm bone plug off the patella and a 10 by 25 mm bone plug off the tibia. Medial and lateral parapatellar portals are made. Healing of the first stage bone grafting should be evident. A notchplasty should be performed to remove any intercondylar notch osteophytes. The PCL femoral tunnel anatomic locations are identified, and the reamers are used as guides for the guide pins, which are drilled through the anterolateral portal. The ALB is overreamed with an 11 mm reamer, and the PMB is overreamed with a 7 mm reamer both to a depth of 25 mm, and passing stitches are placed. The inferior aspect of the PMB tunnel is notched. The ACL femoral tunnel guide pin is now drilled at the anatomic attachment using an over-the-top guide placed through an accessory anteromedial portal. This is overreamed with a 10 mm reamer to a depth of 25 mm. A posteromedial portal is now made to prepare for the PCL tibial tunnel placement. The guide pin is drilled at the bundle ridge for the PCL tibial tunnel. After the guide pin is drilled, intraoperative fluoroscopic imaging confirms that it is in the desired position. After meniscal assessment and repair if necessary, the PCL tibial tunnel is overreamed with a 12 mm acorn reamer. The reaming should be completed by hand to protect the neurovascular structures. A gore smoother is passed up the tunnel to smooth off the intra-articular tunnel aperture, and the end is pulled out the anterolateral portal. The ACL tibial tunnel is identified next, adjacent to the anterior horn of the lateral meniscus. Previous bone grafting should be thoroughly debrided. A guide pin is drilled and overreamed with a 10 mm acorn reamer. The PMB graft is passed in the femur and fixed with a 7 by 20 mm bioabsorbable screw, and the ALB bone plug, cortical side up, is passed in the femur and fixed with a 7 by 20 mm titanium screw. The sutures and opposite ends of the PCL grafts are passed through the ends of the gore smoother and shuttled down the tibial tunnel. The ACL graft is passed in the femur and fixed with a 7 by 20 mm titanium screw. The FCL graft is passed into the femoral tunnel and fixed with a 7 by 20 mm bioabsorbable screw, and then passed down to the fibular head tunnel. The PCL final tibial fixation is performed first with 2 6.5 mm screws and spiked washers. The ALB is fixed first at 90 degrees, followed by the PMB at 0 degrees. The ACL is then fixed in the tibia with a 9 by 20 mm titanium screw and extension. The FCL is fixed in the fibular head with a 7 by 20 mm bioabsorbable screw, with the knee at 20 degrees of flexion and a slight valgus reduction force. Finally, the MCL is fixed in the femoral tunnel with a 7 by 20 mm bioabsorbable screw at 20 degrees of flexion with a slight varus reduction force, following by a fixation to a new Q-fix that is placed 15 mm distal to the joint line to recreate the proximal tibial attachment of the MCL. The deep and superficial tissues are closed with sutures.